Okay, so we'll go on to colon cancers next. Um, colon cancers, if they're caught early, have a much better survival rate, and it's based on what's called staging. What the staging basically tells you is the degree of depth. Okay, stages 1 through 2 are basically still within inside the wall of the lumen. It's when you get into stage 3 where you actually get into the lymphatics, and that's when metastatic spread starts taking place. And usually almost all stages 4s are already metastatic. What we do is we try to stage these individuals. We usually do colonoscopies as a diagnostic procedure. That's why it's usually recommended for everybody to have a colonoscopy by the age of 50 to make sure that you don't have polyps and you can clear them. If you remove the polyps, then usually the person will have a serial exam done once a year to make sure there's no recurrence. But if you can take the polyps out early, it doesn't become cancerous, and you can save that person's life. If you wait too long, eventually it causes obstruction of the wall. The problem with that is that once you obstruct it, all that food content, which is feces at that point, is backed up, and these people have to have diverting colostomies done, okay? Because you can't clear it. If you don't have an obstruction and you can actually clear the GI tract with the cleaning solution, which is the bowel prep, they can tolerate that and it's cleared. Then you can actually do what's called a side-to-side anastomosis. You can actually do repairs without having to do a diverting colostomy. If these people present with obstruction, then you're pretty much relegated to 6 months within a colostomy bag. Okay? It's not permanent, so it's not the end of the world, but it's just uncomfortable for 6 months or so. Infections may also take place in these different forms of the GI tract. Meckel's diverticulitis is something that we see in the small bowel tract. Appendicitis, of course, is the appendiceal component that becomes inflamed and infected. We don't exactly know why people get an increased risk of it. Genetically, there seems to be differences. Some people have what's called retrocecal appendix, which is the actual appendix is lying behind the cecum. Very difficult to treat in the sense that it takes a lot longer to do their actual appendectomy. Other people have the appendix lying right on top of the cecum, easy to get to, not a problem. And you'll see that there is genetic variability in this. It's once you notice it, it becomes obvious. It's not put in the literature yet, but just look for it and you'll see what I'm talking about. Colonic diverticulitis is caused by infections of a diverticuli, and then it can perforate, which can be very significant complications. This is what a Meckel's looks like. Meckel's usually are found in the small bowel. It's in remnant from birth, and you can see these outpouchings can become infected, and eventually these are removed surgically. Appendicitis is something that you're going to get called on very frequently in the operating room, okay, especially at night. We were supposed to do these very quickly to prevent perforation. The way you actually diagnose appendicitis is most people the first thing their complaint will be is that they're not hungry. Okay, so people that are not hungry, have right lower quadrant pain are usually typical signs of appendicitis. If you get appendicitis early, the white blood cell count will actually be normal. So that doesn't help you. You will have rebound tenderness over the right lower quadrant, which tells you that the person is developing peritoneal signs. You may also have atypical locations of the appendix, which would be retrocecal, which then the pain is referred to the back, which can make you think that it's a stone. But in this case, when you check it out, you look at your urine, you'll see no blood in it, nothing that would indicate stone. This is urgent, but not emergent, which means that you don't have to cancel another case. You need to get it done just as soon as possible, let's put it that way. Okay? Unless it's fully perforated, then it becomes urgent. Okay? Diverticulosis is a fairly common disease. It occurs in about 10 to 20% of people over the age of 50. It's greatest in the descending and sigmoid colon. It's usually from people's poor diet, and it's usually due to an increased intracavitary pressure from people bearing down very hard. So one of the things that we give these people is stool softeners to soften up the stool so they don't have this problem. But once you get this injury, which is the outpouching of the diverticuli, you can get fecal impactions in it, which then eventually become infected and may also bleed. So you may develop from diverticulosis, which is just an outpouching, into a diverticulitis, which is much more serious. You can also have malabsorptions and maldigestion symptoms, things like steatorrhea, which is impaired absorption of fat. The stool basically floats on the surface of the toilet, and you'll see it has a white appearance. The etiology usually is either small bowel disease, liver, biliary tract disease, or pancreatic exocrine dysfunction. What you develop in this steatorrhea is the development of fat-soluble vitamins deficiency, so ADEC. Okay, so the fat-soluble vitamins are, just remember that as ADEC, vitamin A, D, E, and K. You also see in this disease process you get a lack of absorption of protein, so you get hypoalbuminemia. You also get hypocalcemia and hypomagnesemia. A thing that's really coming into play recently is that we're finding out that a lot of people have this weird disease called gluten enteropathy, also called celiac disease or non-tropical sprue. It's a disease of the small bowel, and it's due to gluten sensitivity. Okay? And we thought this was fairly rare, and actually we're finding out that it's a lot less rare than we thought. It's due to sensitivity to wheat, rye, and barley. Now, most likely these individuals lived, or their family lived in areas that had did not use wheat and rye as their primary source of food. So this is usually found in Europeans that are southern Europeans. Northern Europeans that depended more on rye and barley and wheat for their diet usually don't have gluten sensitivity. But so southern European ancestry usually have a higher incidence of gluten sensitivity. What these people develop is steatorrhea, abdominal pain, weight loss, and fatigue. And it's so easy, just stop the diet of wheat and rye and barley, and these people get better. It's just such a simple solution. And these people seem really strange the way they act. They have sometimes psychological overlays because of the abdominal pain they're constantly having. They feel fatigued, and just simply by changing their diet, these people are cured. What you're seeing is that here in this slide is the digestion of absorption of lipids using pancreatic lipases. What the pancreatic lipases basically do is they break down the phospholipids into monoglycerides and fatty acids, and eventually these will get absorbed into your system. If you have an inability to produce the pancreatic lipases or the monoglyceride or the pancreatic lipases to break all this stuff down, then you don't get absorption that takes place properly. That's what leads to steatorrhea. This is a normal bowel on this side, and you see the celiac sprue disease. Look how this basically loses the villi, which is the decrease the absorption capability of the intestinal wall. What you see in the gluten people is that they get villus injury as well as mucosal damage, and eventually they get malnutrition that takes place. And so this is a nutritional problem. Even though they're taking in plenty of calories and stuff, it's just something that they can't absorb and they can't tolerate. Short bowel syndrome is something that can occur after surgery. This is when you have to have somebody with, say, a gunshot wound or has had tumors, and they've had to remove a large portion of the small bowel. As a consequence, the person will develop diarrhea, steatorrhea. They also get trace element deficiencies, as well as electrolyte deficiencies such as hyponatremia and hypokalemia. Where you also see problems is if a person has had a complete gastrectomy or a very significant gastrectomy, you can get also steatorrhea, low folate, B12, and iron deficiency anemias. GI bleeds is the next subject matter. In GI bleeds, you've got to be on top of your game because these people can bleed out significantly before you know it. They also have, of course, the increased risk of developing aspiration syndromes with blood inside their stomachs. So that's another thing to be concerned about. Eventually, if you don't control the bleeding fairly quickly, eventually the kidneys begin to fail, and you get fairly big problems in that respect. Upper GI bleeds are usually due to ulcers, erosions, and what we're going to talk about again, and we'll talk about the liver, is varices, Mallory-Weiss tears. They occur from massive vomiting, usually it's associated with alcoholism as well. Somebody who's taking in too much alcohol and then vomit, retch, they can actually tear their they can tear their esophageal and gastric lining when they vomit. Usually what you see initially is they'll vomit up coffee ground emesis, okay, if it's been sitting in the stomach for more than an hour. Okay, the actual hydrochloric acids in the stomach will break down the red blood cells into this coffee ground kind of material. If it gets through into the GI system, into the small bowel, eventually it comes out as melena, which is, again, you can tell that's upper in disease. You don't get melena if you have cancers of the colon. Usually that's really more bloody streaks inside the stool. You don't see the really melena. The melena has to be a byproduct of acid breakdown. Okay, so usually it indicates to you upper GI tract bleeding. Does it always apply? Not necessarily, but it's pretty much consistent. Potentially with upper GI bleeding is you can get massive blood loss. You see an increase in BUN and nitrogen absorption through the small bowel. And endoscopically, coagulation becomes a big problem. If 0.5% will actually go into perforation, and their aspiration risk is also high. If you have varices, what we do is actually we'll do a ligation, okay, which we'll do that endoscopically, or sometimes we'll have to go to the next step, which is the TIPS procedure, or the portal systemic shunt. This is a Mallory-Weiss tear. This is what it actually looks like. Okay. You get mucosal tearing, and you'll go into the actual blood vessels beneath it, and it'll cause a significant amount of hemorrhages. There's a lot of blood vessels along the esophageal wall. It's mostly veins, so it can cause a pretty continuous bleeding that takes place, especially if you have portal hypertension. That's a double whammy effect of Mallory-Weiss tear in somebody who's an alcoholic with already increases in portal systemic pressures. This is the nice picture showing you the esophageal varices that develop from cirrhosis. And you can see how the actual varices get very much enlarged. And you can see here a very severe form of gastritis. This is not a modified picture. This is how red it is. This is what we call a very angry stomach. These people, anytime you touch it, it bleeds. So it's a kind of a nightmare. You can see this is a pathological specimen that's been removed out of the patient. Right, and this picture was taken right in the operating room. That's why it looks so fresh. GI bleeding can also occur in the lower GI system. Usually what you get with that is once you get below the stomach is you start getting what's called hematochezia, which is more bright redder blood inside the stool. It could be from polyps, it could be from cancers. Okay, if it's really, really bright red, it could be something benign like a hemorrhoid or a fissure, but you still got to go check. Okay, so a lot of times we'll be doing colonoscopy, somebody for bleeding, and you can actually lose a lot of blood from a hemorrhoid. You may not think so, but people can actually become very significantly anemic from it. But you still got to check and make sure that you don't have a cancer. You'll see every once in a while people will make the mistake of they'll just say, well, the person has hemorrhoids and that's it. They'll make the diagnosis. And then they'll miss that the person has a cancer, and they'll come back 6 months later with metastatic disease. So you got to make sure that you look. Inflammatory bowel diseases like Crohn's disease or ulcerative colitis also cause a lot of bleeding. So that's also another problem. As for lower esophageal bleeding, the other etiologies can be from diverticulosis, okay, where you actually, as the diverticuli form, they look for the weakest portion of the wall. And that weakest portion is where the insertion point of where the artery is going into and provides a blood supply to that colon. Okay? So that's where the vagination and the actual diverticuli form. The problem with it is if it pushes into the blood vessel too much, it eventually bleeds. And it can be pretty active. I mean, you'll drop hemoglobin by 4 to 5 units in a matter of a few hours. Usually these people complain that when they go to the bathroom, it's got bright red blood. And unfortunately, by the time they come into the hospital, they're in shock. And then you're asked to do a colonoscopy on these individuals, and you can't find a bleeder. Okay? And the reason you can't find the bleeder is they got hypotensive, and that area had low levels of perfusion, so the bleeding stopped. Now, what ends up happening is you start tanking these people back up, and then it reperforates and it rebleeds again. So sometimes we'll have to send these people to get red blood cells that are tagged and to indicate to you where the bleeding is taking place. And then we'll have to remove that portion of the colon. So somebody who's already anemic, a little bit hypotensive, a little shocky, and then you have to take them in the operating room, you're looking at much higher risk. Those kind of patients should be put in an A-line in them and do everything ahead of time to get them fluid resuscitated so you don't get in trouble once you put them to sleep. These presenting signs that you see with these kind of problems is hematopesia and bright red blood for rectum, and of course you get the foul-smelling, bone, bowel movements that you see. Complications are bowel prep, more continuous blood loss will lead to severe dehydration, and you get massive hemorrhaging, which of course, that's the reason it's major problem we're seeing. The last set of slides is on pancreatic diseases. Okay, now what I've done for you is I pretty much covered what we encounter in the operating room. Okay, there's still many other GI diseases that you can sit here and talk for days. Okay, it's a subspecialty all by itself. Okay, and people spend all their life doing, just doing that. Okay, so you'll meet our gastroenterologists. Our guys are very good, so they can do a lot of things that a lot of places I've seen would have to take in the operating room. We can actually get away with not having to take people to the operating room by fixing them in the endoscopy suite. With that, of course, it means that you're taking very sick patients that would normally have gone to the operating room, and now you're taking care of them in the endo suite. So when you get put into the endoscopy suite, don't think of it as punishment. It actually is one of the most challenging places you're going to work at, okay, in the sense of full stomachs, high risk for possible aspiration, hemodynamic instability, sick people that nobody else wants to touch. When a surgeon comes by and he looks at the patient, he starts laughing and he walks away. The endoscopist comes by and he does this. Yay. Okay? So, it's a very different thought process. They don't worry about it as much as the surgeons do because they know that we can get them through it. Okay? But we'll pump them full of fluids while they're trying to get their procedures done. So just be aware that you will be challenged up there quite a bit. Pancreatic diseases is the next subject matter. Pancreatic diseases can be fairly complicated in the sense that they can cause significant complications for the individual. The pancreas has several systems in it. It has the endocrine and as well as exocrine capability. The exocrine capability is what we're going to talk about today more so, and that's the ability to release pancreatic, basically digestive enzymes and bicarbonate to neutralize the acid that's been produced by the stomach. So the pancreas is very important to start helping digest the material that's now arrived out of the stomach. The pancreas has, of course, its different kinds of cells, which I'm not going to talk about in great detail, but know that the islands of Langerhans are very important for producing the endocrine function of insulin and glucagon. Okay? But what we're going to talk about instead is we're going to talk about the acinar cells, which actually produce the enzymes such as pancreatic amylases, which break down carbohydrates, or you get proteolytic zymogens, which break down proteins, as well as pancreatic lipases, which break down fats. So this organ system basically helps and is vital for breaking down most of the digestive stuff that you've taken in. Now, one of the processes that can affect this is that these pancreatic enzymes can attack itself. And the ducts are very important to stay intact, because if the ducts are staying intact, when you secrete this material in, it travels into the duodenum where it starts doing its work. If you have damage of those pancreatic ducts, though, then the actual pancreas will begin to auto-digest itself and develop what's called pancreatitis. Okay? And pancreatitis can be a devastating disease. It's like taking a hand grenade and throwing it in somebody's belly. And it's the best description I can give you. When you open up the person's belly with pancreatitis, if you do that, which is not a good idea, but every once in a while some people get fooled. Not so much now because of the CT scans. It sort of tells us what's going on. But in the old days, you'd actually sometimes open up somebody's belly because you thought they had some kind of perforation, which would cause pancreatitis as well. And you'd look inside the belly, and it would be saponified. Okay, the actual peritoneal wall would look white. Okay, the actual peritoneum was actually being attacked by the pancreatic enzymes, and it causes saponification, which is like a soap-like process. The pancreas in that situation that becomes very grossly enlarged is severe pain that's almost difficult to treat with most high doses of narcotics. So it becomes a very issue of controlling pain as well. The problem is once you develop pancreatitis, the chance of you recurring is fairly high. So it's another issue. You see acute severe abdominal pain, dyspnea from pleural effusions or ascites. Patients can go into fulminant fever and high levels of shock. They become obtunded, psychotic, and sometimes they will develop, of course, pancreatitis is also associated with ethanol, and then they go through ethanol withdrawal on top of it all. They will develop malabsorption syndromes, of course, because if you don't have the enzymes in the proper place, now they can't uptake the normal things. And they may develop tetany due to hypocalcemia. And the calcemia is the reason it's being is the calcium. Remember I told you saponification looks white? That's where the calcium's at. The calcium's actually now in the peritoneum. It's being absorbed by that saponification process. So you can get a very severe hypocalcemia. They can be deadly. Physical signs include Gray-Turner sign and Cullen sign. I'll show you that in a minute. You have what's called Ranson's criteria to follow with acute pancreatitis. What I would look for more so is look for serum amylases, which is not part of Ranson's disease, Ranson's criteria, which I think is a problem, but you see a significant increases in serum amylase. Etiology could be things like gallstones that are obstructing the actual pancreatic duct, because when you go back, let's see if I can show you this picture here. See right here, the common bile duct comes together with the pancreatic duct at the sphincter of Oddi. Okay? So if you have an actual stone that travels down the common bile duct and it gets impinged to here in the sphincter of Oddi and you can't get out, then the actual pancreatic duct will not be able to expel its contents and begins to get filled with this material and eventually breaks down the pancreatic ducts and causes pancreatitis. So that's a gallbladder-induced, gallstone-induced pancreatitis. You also have alcohol, things which, of course, are toxins that can cause inflammation at the sphincter of Oddi and cause problems. You can also have infections that affect the pancreatic ducts as well. You get hyperlipidemia. Patients with AIDS have a very high incidence of developing acute pancreatitis as well. We think it's because the immunosuppression allows them to be attacked by many different kinds of bacteria or viruses. Hyperparathyroidism has also been associated with acute pancreatitis. Blunt trauma, somebody punching you in the belly, and post-surgical trauma can also cause acute pancreatitis. The one that you have to worry about the most for this is things like gallbladder surgery, where the guy didn't pick up on there was gallstones inside the common bile duct, and now the duct has developed gallstone pancreatitis, and that's usually a post-surgical complication. The way we deal with it is we'll do what's called an ERCP. The way we do ERCPs here is we intubate everybody. Everybody gets intubated. If you go to Tampa, you're going to have the great pleasure of doing these with upside down with under sedation. I refuse to do that anymore. I'm tired of it. So I basically stopped doing that almost 10 years ago, 11 years ago. It's not, to me, it's not easy. And it's at very high risk for aspirating. So to me, it's not worth doing it that way. So I intubate everybody for ERCPs. It's so much easier. It's calmer. The surgeons take their time, and it seems like we have less problems with pancreatitis. What happens is if you're sedating somebody and you're having them upside down, you're constantly being worried about giving them too much and they go apneic. So you're underdosing them, and as a consequence of that, the person is constantly bucking, and that bucking motion can cause the pancreatitis to occur after the ERCP procedure. So not a good thing. If you're having gallstone pancreatitis, what we need to do in that situation when you do the endoscopic retrograde cholecysto pancreaduodenoscopy is that we go in there and identify the sphincter of Oddi. We put a wire into the sphincter of Oddi and into the common bile duct, and then we put in a special catheter that has a wire that can cauterize. And what the cautery does is basically cuts through the sphincter of Oddi and opens it up. And then the stone will then fall out. Okay? It's actually pretty impressive when you see it done. You'll actually see these large stones sort of jump out of the duct, and then all of a sudden all the stuff behind it, which is all the bile and all the pancreatic lipases and stuff come out of it, which looks like pretty toxic yellow-green material that looks pretty ugly. Okay? So you know you're doing that person a lot of good. Ranson's criteria, I'm not going to ask you to memorize. I think it's something that, just know that it exists. Okay? What it basically is it's indicating to you a set of criteria to diagnose pancreatitis. I think this is out of your scope, and I think that's not worth memorizing. But Dr. Saab presented this before. I just don't think it's useful. I don't use it myself, so I'm not expect you to memorize it. So it's not going to be a test. Just know that it exists. That is, there is a criteria, and you just have to know what the name of it is. That's what I might ask you on the test. Okay? This is what Cullen's sign is. Cullen's sign is in the middle, okay? And Gray-Turner's sign is on the side. It usually indicates retroperitoneal hemorrhaging, okay? But it's also a sign of pancreatitis, because the pancreatitis causes inflammation and perforations of little blood vessels because of the autodigestive enzymes, and causes what's called Great Turner sign. Pancreatic cancers is the last slide for this discussion. Thank goodness this incidence hasn't really gone up in the last few years. The problem is that pancreatic cancer has a devastating disease. If it doesn't get removed, the mortality rate's very, very high. Okay? Even when it is removed, the mortality rate's still higher than we want it to be. The procedure actually involves this huge process called the Whipple procedure. It is a very big procedure. Okay? 8 to 10 hours of operation time. Okay? Sometimes if you have a really good surgeon, it'll be 4 to 5 hours, but most of the time it's an all-day event. Okay? So these people need everything possible: A-line, PA catheter, epidural for pain control. You name it, you do it for these people. Okay? Some of the new, at least when I was working in Moffitt, we would put these people through a, what's the name of that thing now? Electron bombardment unit, and we would actually bombard the tumor intraoperatively. So it was pretty high-risk stuff. The problem with cancers of this level is if you don't catch it early, the mortality rate is close to 100%. So you really have to catch it early. Sometimes you get lucky and you catch somebody early and you're able to do this curative procedure. This is what the Whipple procedure is. Okay, just understand that what we do is we cut out the small bowel, we cut out the distal portion of the stomach, and then reattach everything back together. So it's a pretty extensive operative procedure. Okay, and there's several complications that can take place. One is you're reattaching pancreas to the small bowel. Okay, you can imagine what that would be like. You're trying to get pancreas, which is kind of a doughy organ, connected up to intestine. There's a good possibility that's going to break down. The enzymes are going to break down the suture line. Okay, then you're going to do the biliary tract, and you're going to attach that to the small bowel. These are big, big procedures in the sense of high-risk complications with these as well.